Good morning, everyone, and welcome to our Nestle Health Science Symposium. We will get started in just a few minutes. All right, well, welcome everyone. We're really excited to host you for our second Nestle Health Science Symposium. This conference the topic will focus on nutrition management of Crohn's disease, new advances and perspectives. We have two fantastic speakers today, but because it's been a little bit since we've been on Pathable, I just wanted to give everyone a quick reminder and then also allow those that are still linking in to join us for the actual conversation when it starts in a few minutes. So let me go ahead and do our quick reminders. How to use the Pathable Platform. So let's quickly become familiar with how to use the platform. We're currently in a plenary session, and I just want to quickly review how to navigate this page. We recommend reviewing the presentation in theater mode. This button can be found at the bottom right here below the broadcast screen. To chat with others in the plenary session, you'll need to be on the chat tab, and I can see many of you have already said hi to each other and good morning. So that's fantastic that we've already had a chance to connect virtually. If you haven't had a chance already, please feel free to type into the chat box by saying hello and letting us know where you're joining us from today. If you're interested in seeing who else is attending today, you can also jump over to the People tab, and that will show you also who else is on our plenary this morning. And so lastly, before I hand it over, I just wanted to let everyone know in the event that you need help, at the top on Pathable, you should see an attendee resource menu option. There are some fantastic resources available there to you, or you can also email the Pathable support or info@improvecarenow.org, and our team will be happy to assist you. So for now, I'm going to go ahead and stop sharing, and I'll turn it over to Shahzad, our Improve Care Now Clinical Director, to get us started.
Thank you, Julie. Welcome, everyone. Kind of bright and early, and then certainly for some folks on the West Coast and internationally, definitely different timelines. It's really exciting to see a number of people joining us for this. It's my pleasure and honor to introduce the speakers today for the Nestle Symposium. I'll make quick introductions and then hand it over to Dr. Lewis, who will then hand it over to Dr. Albenberg afterwards. So the first speaker is Dr. James Lewis, who is a professor of medicine and epidemiology and a senior scholar in the Center for Clinical Epidemiology and Biostatistics with the associate directorship of the IBD program. He's also the director of the clinical research in the GI division at UPenn and the School of Medicine at UPenn. He serves as the director of Human Research Core of Penn Center for Nutrition Sciences and Medicine, and is currently the lead scientist for the Crohn's and Colitis Foundation's IBD Plexus Research Program. So a distinguished scholar indeed, and we are really happy to have him start this symposium off. The second speaker is Lindsey Albenberg. She's an assistant professor of pediatrics at Perelman School of Medicine at University of Pennsylvania and an attending physician in the Division of Gastroenterology, Hepatology, and Nutrition at Children's Hospital of Philadelphia. She's the program director for the Fellowship in Advanced Inflammatory Bowel Diseases and a researcher focusing on the response of the gut microbiota and dietary modification in IBD with the IBD Center. So without further ado and taking more time, Dr. Lewis, you're up.
Thanks, Shahzad. Let me just share my screen. Just a quick question, Shahzad, are you getting slideshow mode or speaker mode?
I'm getting speaker mode.
All right.
It's me. I don't know whether.
Yeah, I'll switch to sharing a different mode.
Yep.
Here we go. Now, hopefully you're getting speaker mode, correct?
Yes, it is.
I mean, slideshow mode, great. Well, good morning, everybody. It's really a pleasure to be here and to join this group. You all have an incredible success story, an incredible, really way to follow the way you've improved the care of children with IBD. And so for me, as someone who takes care of adults with IBD, it's really fun to be here and share with you. I'm going to just open just by mentioning a little bit conflicts of interest. I've done consulting for lots of pharmaceutical companies and had research support for many. Probably the only thing relevant to today's discussion would be research support from Nestle Health Science. You know, so we have lots of ways that we can think about using diet as part of the therapy for people with inflammatory bowel disease. At the simplest level, we can think about adding things to people's diet in the form of a supplement. We can think about exclusion diets where we take certain things out of one's diet and replace them with more of the things that they're already eating or other things. And Lindsey is going to talk to you about that. And I'm going to provide just an introduction thinking about where things stand in terms of using enteral nutrition formulas. I'm not really going to talk about parenteral nutrition in the short presentation today. So enteral formulas, I think all of you are probably familiar with these. These are basically meal replacement liquid formulas. These are things that you've used for years in your practice. As you know, the nitrogen source can be elemental, semi-elemental, or polymeric. The fat content can be quite variable. The carbohydrates in most of these formulas are predominantly glucose, fructose, and sucrose. And most of them have no or minimal fiber content, but that's not true for all of them. And their uses can be as a caloric supplement. This is when you tell somebody, you know, to take one of these supplements, you know, between breakfast and lunch, and maybe one, but you know, after dinner. We can use them as partial enteral nutrition, which I think of as providing about 50% of one's daily caloric needs from the formula. And then you can think about using them as exclusive enteral nutrition, meaning providing more than 90% of the calories from formula. And we have a fair amount of data. These are old data at this point, but recently summarized in a newer Cochrane review of the effectiveness of exclusive enteral nutrition as treatment for Crohn's disease. On the left-hand panel is a forest plot that compared non-elemental to elemental formulas. And I think the striking result is at the bottom of there, that there's absolutely no difference in efficacy, whether you're using an elemental or non-elemental formula. The only big difference is that one tastes a lot better than the other. So in usual care, there's probably not a whole lot of reason to be using an elemental formula for most patients. The middle panel, I also think is striking in the fact that, you know, in these trials conducted during this time period, the remission rates for Crohn's disease with these exclusive enteral nutrition approaches were in the neighborhood of 70%. And I always say, if we had a drug that didn't cause immunosuppression and resulted in remission rates of 70%, this would be the blockbuster drug for Crohn's disease. And indeed, these remission rates, while it's impossible to do a placebo-controlled trial of food for the most part, I think you can get a sense that if you compare these to the remission rates that were seen in the placebo arms of clinical trials done in the same time period, this is dramatically higher than that 20% roughly remission rate at that time period. Now, I told you already about is there an advantage or disadvantage of elemental versus semi-elemental or defined proteins. Here, I'm just pointing out that the amount of fat in the formula also doesn't seem, for the most part, to make much of a difference. So again, strikingly equal results with high and low fat formulas. People often question, are we just making people feel better, or is there actually evidence that we're achieving healing? These are the results of a famous pediatric study, although a relatively small study, that compared a polymeric diet to corticosteroids in children with Crohn's disease. And you can see that with both of these therapies, the PCDAI got better. You can see that the CRPs improved with both of these therapies over the course of 10 weeks. But only with the nutritional approach did endoscopy and histology improve. And that improved both in the ileum and the colon, which I think is important to consider as well. Lastly, everything I've talked about up till now has been focusing on exclusive enteral nutrition, but there's growing data that partial enteral nutrition may be an effective therapy as well. This is a recently published systematic review and meta-analysis that looked at partial enteral nutrition to prevent Crohn's disease relapse when used in combination with medical therapy. There were 8 studies included in this systematic review. It's pretty obvious 6 of these came from Japan. But nonetheless, you can see if you look at the forest plot on the right that there was a fairly consistent finding that partial enteral nutrition seemed to be favorable when used in combination with medical therapy. All of this has come together to lead to updated guidelines from ECHO and ESPGHAN that children with active luminal Crohn's disease, dietary therapy with exclusive enteral nutrition can be recommended as a first-line therapy for induction of remission. And actually 92% agreement on that amongst the people who put together the guideline. And then in children with low risk Crohn's disease who achieve clinical remission, monotherapy with maintenance enteral nutrition, at least 50% of the daily energy requirement, so partial enteral nutrition can prolong remission. And again, there was over 85% agreement on this. Well, it's great to know that these work and these are available for you, but I think it would be equally useful if we could actually figure out how they work. And I would argue that that has remained elusive to date, that we certainly have some ideas, and I'm going to just touch on them briefly. The first of this is obviously, is it the formula or is it the food? And one way to get a hint at this is to look at some of the studies of exclusive enteral nutrition versus partial enteral nutrition, because in both of these groups, they're getting lots of formula, but in one, they're getting more food. This is some work that Lindsey and I worked on together in the past, along with Dale Lee and many other people. And so here in this PLEASE study, we had 90 children with active Crohn's disease who were treated at the discretion of their treating physician. 38 of these were given nutrition therapy and 52 were given anti-TNF therapy. And we tracked their symptoms, we tracked their calprotectins, we tracked their diet, and we looked at the microbiome over the course of 8 weeks. In fact, did several times over the course of 8 weeks. We did this study in 3 sites. And it turned out that at one of the sites, the children were getting partial enteral nutrition, and at the other 2 sites, they were getting exclusive enteral nutrition based on the definition of the percent of calories that they were taking in per day from food, which we assessed with 24-hour dietary recalls. And so you can see that the partial enteral nutrition group was getting almost half of their calories from table food versus 10% in the exclusive enteral nutrition group. And obviously the anti-TNF group was getting all of their calories from food. And so if you looked at response of fecal calprotectin, so getting your calprotectin below either 50 or below 250 by 8 weeks, you can see that while anti-TNF therapy did the best, exclusive enteral nutrition to get your calprotectin under 250 was actually quite effective, with 45% of the children achieving that versus only 14% with partial enteral nutrition. Albeit none of the therapies were that great at getting to below 50, with anti-TNF being the best, obviously, but neither exclusive enteral nutrition nor partial enteral nutrition were particularly successful at completely normalizing the calprotectin. But the better efficacy with exclusive enteronutrition over partial enteronutrition does suggest that maybe there was something in the food that the partial enteronutrition children were consuming that was driving the inflammation. We can also get some insights into whether the microbiome was the source of this through that same study. And here I'm showing you change in microbiome over time relative to the microbiome of a healthy child without Crohn's disease or ulcerative colitis. And this is just sort of the distribution around a centroid of the microbiome if you plotted it in a multidimensional space. And I want you to just focus on the sort of khaki and green. So these are the exclusive enteronutrition children, and you can see within 1 week, their microbiome actually became very different from what a normal healthy child's was. In contrast, if you look at the sort of purple and pink, you can see that within 1 week of anti-TNF therapy, their microbiome was moving towards that of a healthy child. And then if you focus at the end, now look at the green and this sort of pinkish color. These are the responders to either diet therapy or anti-TNF. And you can see by 8 weeks, they now have a therapy that looks very similar to the healthy child, suggesting that some of the dysbiosis of IBD is driven by inflammation, and that at least initially, exclusive enteronutrition results in what we might call more dysbiosis, not normalization. In fact, we've further studied that in healthy volunteers, where we had people follow either an omnivore diet, a vegan diet, or exclusive enteronutrition. So these are people without bowel inflammation now. And what you can see is over the course of 5 days, there's really no change in the microbiome if you're on an omnivore diet or a vegan diet and you just stay on those diets. But if you take an omnivore and put them on exclusive enteronutrition, within 5 days, again, you see this dramatic shift in the microbiome away from what we would consider healthy. That doesn't mean that it's unhealthy. It just means you're changing the microbiome in a distinct way. Certainly other people have been thinking about this, like what can we do with whole food to sort of match what's happening with exclusive enteronutrition. This is the CDED Treat study that was published a year or so ago. And here what they showed that if you took food that mimicked EEN by excluding dietary components like lactose, alcohol, and gluten, matched the macronutrient and vitamin content, and then give it to healthy volunteers, that you again would see fairly similar changes in the microbiome and the metabolome. And then they did a very small open label trial in 5 children with this, and were able to show some improvement in PCDAI and Calprotectin, although again, you'll note that most of the Calprotectins did not totally normalize. All right, and then lastly, so what is the role of dietary fiber and the effects on the gut metabolome of these therapies? So that same study that I alluded to with the healthy volunteers before, we can look at the sort of dietary phase. This is a complicated study, and I'm not going to go into great detail about how we wiped out the gut microbiome and then watched it recover. But this was done over the course of 15 days in a controlled feeding experiment. And we were able to track their metabolome changes, and we scored this with sort of like a zip code. So by each phase of the study, did the metabolome, did a given metabolite go up? Did it stay the same or go down, so that they could have, so if it had a code of 2312, that metabolite stayed stable while they were on the diet therapy, went down with antibiotics and PEG, and then went up shortly thereafter and then stabilized. And so I'll just highlight the fact that if we looked at the 669 known metabolites, that the people who were on a vegan diet, they all stayed stable at baseline. Those are the ones that start with 2. The only ones that actually went up initially were people who were on an omnivore diet. But when you put people on exclusive enteronutrition, there were a number of metabolites that go down. And perhaps those metabolites are a signal for the mechanism of action of exclusive enteronutrition, how it works, the things that it takes out of the lumen of your gut when you go on EEN as opposed to eating a regular diet. All right, I'm going to just wrap up with just a few comments on other uses of enteral nutrition. One would be preoperative therapy, and the other is in conjunction with other medical therapies. This is just one of many studies that have looked at exclusive enteral nutrition in the pre-op state. And what you can see this is a cohort study of some people who got preoperative exclusive enteral nutrition, about 38 people and 76 matched controls. And if you look on the bottom left, you can see that the group who got preoperative nutrition therapy had a shorter length of operation. And if you look on the right, they actually had less postoperative complications. So this is something you can definitely do for your patients who don't need emergency surgery, but who, particularly if they're a bit malnourished. And then lastly, what about using this to augment the effectiveness of our induction therapy with medications? So this is a relatively recent systematic review and meta-analysis looking at a number of studies now that have combined enteral nutrition therapy with various medical therapies, extending this concept of showing them to be more effective. And so these are the proportion of people who achieved a long-term remission. And you can see that for almost all of these studies, the combination was more effective than using the medication alone, and this was highly statistically significant in the meta-analysis. I'll therefore wrap up to say exclusive enteral nutrition is clearly an effective therapy for Crohn's disease. Use of this in pediatric Crohn's disease management is supported by the latest ECHO guidelines. There are challenges related to adherence and long-term strategies. And so when using this, I very much encourage you to use a palatable formula that doesn't require NG tubes if possible. Certainly in adults, that's the approach that I take. And we should all be thinking about novel uses such as preoperative therapy and adjunct to medical therapy. And for sure, I think one of the ways that I like to use this is just as an alternative to steroids when we're bridging between therapies. So I'm going to wrap up there, hand this over to Lindsey, and then I look forward to some discussion at the end.
All right, thanks so much. I'm gonna share my screen. All right, so happy to be back at the ICN community conference. This is always one of my favorite groups to discuss diet and IBD with. I will build off of Jim's excellent talk on EEN, and we'll shift to focus on whole food-based diets, and specifically the newest kid on the block, the Crohn's disease exclusion diet. So I have a few potential conflicts of interest shown here. All right, so in a healthy gut environment, we know that the microbial species are compartmentalized from the host. There are two mucus layers and a monolayer of epithelial cells, and we know that the gut microbes serve many important functions and keep our mucosal immune system in balance, and that a disruption of this balance by genetic risk plus environmental risk factors, we think can trigger dysbiosis and inflammation, eventually leading to IBD. And we know that diet is one of the major environmental factors to which the gut is exposed. So it makes sense that diet may be involved in the development of IBD and may serve as a potential therapy for IBD. From an epidemiologic perspective, there are evidence to suggest that certain dietary patterns may predispose to the development of IBD. And this can really help us to generate hypotheses and can lend insight into, I think, potential mechanisms and ultimately potential therapies for IBD. This was a recently published study where the authors looked at food frequency questionnaires, which were collected prospectively over an 8-year period of time in 3 large observational cohort studies that were enrolling healthy adults. And these were studies that were following large groups of healthy individuals over time. The focus was not necessarily on IBD, but people ended up developing IBD. And the nice thing here was that there were over 4 million person years of follow-up, and 328 individuals developed Crohn's disease and 428 individuals developed UC. And they calculated something called the Empiric Dietary Inflammatory Pattern Score, or the EDIP, which is a weighted sum of 18 food groups with a higher sum equaling a more pro-inflammatory diet. This score has been previously shown to be associated with elevated serum inflammatory markers like CRP. And what they found was that the highest quartile of EDIP scores, those individuals had a 51% increased risk of developing Crohn's disease. Now, in this study, there was no association of dietary inflammatory potential with ulcerative colitis, but I still think that this really raises the question, is there something bad or potentially harmful in our Western diet that, through effects on the microbiome and the mucosal immune system, leads to inflammation in genetically susceptible individuals? And more importantly, can we use diet to reverse or treat this process? The table on the left comes from a recent review, which I think really nicely summarizes foods and nutrients that have been shown mostly in animal models to have an impact on gut barrier function. And some of these food components will be familiar, like fructose and dietary emulsifiers, both ubiquitous in processed foods and highly prevalent in the Western diet. And so this is really the basis for many of the therapeutic whole food-based diets that have been proposed for the treatment of IBD, primarily Crohn's disease, but there's a lot out there. It's not always evidence-based. And we know that what should I eat is one of the #1 questions we get from patients. And it's also, diet and IBD is also a major research priority. So Jim really nicely summarized EEN, which is the original dietary therapy for Crohn's disease and one that is still used frequently around the world. I use it frequently in my practice, and there are a lot of benefits to EEN, such as the fact that it's at least as effective as corticosteroids. It's associated with mucosal healing. It works quickly, it improves nutritional status and bone health, and there are essentially no side effects, but there are also some downsides. So it requires resources, education, and dedication on both sides, provider and patient. And also it was really meant to be an induction of remission therapy. So we and others have adapted EEN as a maintenance strategy, but it's definitely a more limited population of patients who will be willing to follow such a restrictive diet in the long term. This was a survey from Morgan Lawley and Eitan Wine, where they asked 146 pediatric IBD-focused gastroenterologists from 26 countries about EEN experience and strategies. There was a lot of variation in practice patterns, but the largest barrier really in all parts of the world was poor adherence due to the palatability of the formula, and also poor adherence because of monotony and taste fatigue. And this was the case in most regions, except for the UK, where actually 55% of respondents reported no barriers to running an EEN program. So what are the alternatives? So there's partial enteral nutrition, with which Jim mentioned, and I'll talk about a little bit more. The specific carbohydrate diet, which Jim and I could give a separate talk on, but will not be the focus today. CD Treat, which Jim mentioned. The Crohn's disease exclusion diet, which I'll also talk about today, and also precision nutrition or personalized microbe-driven diets, which I really hope will be the future, but we'll talk a little bit more about PEN and CDED. So we'll start with partial enteral nutrition. This was a randomized trial back in 2006 where 50 children with Crohn's disease with a PCDAI greater than 20 were randomized to receive EEN with 100% calories from formula versus PEN with 50% of calories from formula and otherwise an unrestricted diet. The formula here was elemental and the duration of treatment was 6 weeks. And the primary outcome was remission with a PCDAI less than 10, which was achieved by only 15% of patients in the PEN group compared to 42% of patients in the EEN group. The overall reduction in PCDAI was greater in the EEN group, and only in the EEN group were improvements in hemoglobin, albumin, and SED rate seen. So this suggested that 50% of calories plus an unrestricted diet really was not very effective for induction of remission. And then Jim mentioned the PLEASE study where using calprotectin as an estimate for mucosal healing, we really saw the same thing where the percentage of patients with a calprotectin less than 250 or less than 250 at week 8 was lower in the PEN group compared to the EEN group and the anti-TNF group. So it looks like the amount of regular food matters, but perhaps both the amount and type of food matters. And this was a recent study with 25 children with clinically and endoscopically active Crohn's disease who were treated with either EEN or PEN for 6 weeks. And the authors originally meant for this to be a randomized trial, but enrollment was low and parents and patients had strong feelings about which treatment they wanted. And so it was open. And there were 13 children in the EEN group, 12 in the PEN group. And in this study, PEN was defined as 75% of calories from formula. And then patients could also have either lunch or dinner from an anti-inflammatory diet plan that was based on locally available foods. Ileocolonoscopy was performed at baseline and at week 6. A thiopurine could be introduced at the 1st or 3rd week visit, and there were 3 patients who withdrew from the study. And interestingly, there were no differences here between the 2 groups in terms of response, remission, or endoscopic response and remission. And while small and not randomized, we so rarely have endoscopic outcomes in our pediatric studies. So I think that this is really interesting and brings us to the, I guess, newest kid on the block, which is the CDED or the Crohn's disease exclusion diet, which was developed by Ari Levine and Rotem Sigal-Boneth. And what they did is they essentially said, you know, we know that Western diet is bad, EEN is good, but difficult. And so the thought was to combine EEN or PEN with a whole food-based diet, which eliminates potentially pro-inflammatory components of a Western diet and requires a minimum amount of beneficial fiber. And so essentially what they did was an extensive review of the literature, really focusing on 2 areas. So one was studies of potential effects of dietary factors on host barrier function and immunity in animal models or humans. And so, for example, the potentially detrimental effects of high-fat diets, dietary emulsifiers, and gluten, as well as studies of potential effects of dietary factors on the microbiota, for example, the beneficial effects of dietary fiber. And so they designed the CDED, which is a multi-phase diet, and most of our current data comes from its induction of remission data from the first 2 phases. The first phase is weeks 0 to 6, and the diet excludes or limits animal fat, taurine, red meat, dairy, wheat, alcohol, yeast, the emulsifiers, carrageenan and maltodextrin, sulfates and titanium dioxide, and includes a minimum amount of fiber. The diet consists of mandatory foods like chicken, eggs, white potatoes for resistant starch, apples for pectin, and bananas for resistant starch. It allows in certain quantities fish, white rice, fruits, veggies, oil, herbs, and spices. And in the first phase, 50% of calorie needs come from formula and 50% of calorie needs come from these foods. And then we have phase 2, which is week 6 through 12. Here, the formula is reduced to 25% of calorie needs. The diet remains gluten-free, dairy-free, processed food-free, but there are some important additions, like some of the white potato can be substituted with sweet potato. 1 slice of whole grain bread is allowed daily. A small amount of nuts are allowed daily. Quinoa can be consumed daily. Baking soda can be added, which is helpful for baking. Patients can have some cooked lentils or cooked peas daily, and then a certain amount of oats and also beef can be added weekly as well. So there were originally 2 case series published, the first in 2014, which showed improvement in clinical disease activity in adults and children with active Crohn's disease from baseline to week 6. And then in 2017, again, showing improvement in clinical disease activity in children and adults who had lost response to a biologic despite dose escalation or combination therapy. And then the pediatric RCT, which was published in Gastro in 2019. This was a 12-week trial with randomization 1-to-1 to either the Crohn's disease exclusion diet with 50% of calories from formula or EEN with 100% of calories from formula. At week 6, patients in the CDED arm moved to phase 2 with 25% PEN, and the EEN group transitioned to 25% PEN with a gradual return to a free diet. And the primary outcome here was tolerance. 78 patients were enrolled. Patients were allowed to receive a stable dose of an immunomodulator, or they could start thiopurine at or after week 3 or methotrexate at or after week 6. And so these are the week 6 data, and I will highlight that the PEN plus CDED group seemed to be better tolerated than EEN alone, and this I think is not super surprising. Compliance was actually quite good in both groups, and both diets were equally as effective in terms of response and 2 definitions of remission. And then looking at this a little bit more closely, these are the week 6 PCDAI and CRP data, which show significant improvement in both groups, though you will recognize that in terms of PCDAI, the Pediatric Crohn's Disease Activity Index, this is overall a mild disease cohort. And then here are the Calprotectin data at baseline, week 6, and week 12. In the blue, you see the CDED group, and in the EEN group is in pink. You see significant reduction in calprotectin in both groups from baseline to week 6. By week 12 in the CDED group, you see about a 75% reduction in median fecal calprotectin. And in the EEN group at week 12, you see this potential rebound effect in the EEN group with transition to 25% of calories from formula and 75% of calories from a free diet. They also looked at the stool microbiome in patients, and many of the abnormal features of the gut microbial community that have been associated with active Crohn's disease were addressed by both diets from baseline to week 6. But when you got to week 12 in the EEN group, when the patient started eating more free diet foods, there was a return to the pre-treatment community, while there were ongoing changes in the CDED group. And then this was a recently published post hoc analysis of the CDED trial where they looked at week 3 data. And here you can see response remission and normal CRP remission at week 3 in gray and week 6 in black. They didn't have calprotectin because it wasn't analyzed at week 3. And I think what's interesting here is that you can see that essentially all of the clinical effect can be seen as early as week 3. There were actually 12 non-responders at week 3 in the CDED group, but only 3 of those patients subsequently obtained clinical remission. And then here you can see percentage of patients achieving response, remission, and normal CRP at week 3 with the CDED in gray and EEN in black. And you can see that these are both therapies that work quickly. And same with CRP on the right. In the CDED group and in the EEN group, you see these pretty dramatic reductions in CRP. And in the paper, they describe this trial by diet concept, which I think is really interesting, with this idea that a dietary responsive phenotype may be apparent pretty early on in patients. It's difficult to tease out non-compliance versus true non-responders. But I do think that this has significant implications for positioning for really either therapy. So it can be used as monotherapy, as rescue for patients failing maintenance therapy, as a bridge to biologic therapy, if you're awaiting insurance approval, or if immunosuppressive medications are not appropriate, if you need to update patients on vaccination, or if a patient has abdominal sepsis and needs a cool-off period. And again, remembering that neither of these therapies have immune suppression or really significant side effects. And so in terms of what's to come, there's an adult CDED trial that is complete and has been presented at meetings, but not published, where the formula was excluded completely in one of the arms. And then there's another pediatric trial, which we are participating in, which is similar to the original study, but follows patients out to week 52 and includes a 3rd phase of the diet, which is the maintenance phase, allows even more flexibility in the diet. So I think we'll have longer term outcomes in pediatrics soon. So overall, in terms of the CDED data, I think it's pretty exciting in that it's relatively large as a study for pediatrics and randomized and controlled. It's not powered to be an efficacy trial, but seemed to be as good, possibly better from a tolerance perspective than EEN for induction of remission. I think it's important to remember that this was a mild disease cohort with short disease duration. There was no mucosal healing endpoint, but there was significant reduction in calprotectin. And again, I think the longer term outcomes right now are unknown, but will hopefully be answered by future studies. I think something else that always comes up is how much flexibility is allowed in the diet. And so this always comes up, for example, in phase 1 of the diet, patients are allowed to have 5 strawberries per day. And they were sort of trying to regulate the amount of fiber, but can patients have 8 strawberries or 10 strawberries? So I think there's a lot that we don't know about, sort of the necessity to be like super rigid versus is some flexibility okay, and how much flexibility is okay. So in conclusion, EEN is an effective therapy for Crohn's disease. The CDED has shown a lot of promise to induce remission in Crohn's disease. There are certainly limitations, as Jim also discussed, to the clinical data for dietary therapy and IBD. I think this should not necessarily be a deterrent. I think it's extremely important that this is a shared decision-making process with patients and families. Following objective outcomes is really critical given the limitations in data. And when I talk to families about dietary therapy, we talk about the fact that, this is your drug. And so I expect the same compliance with the therapy, and more importantly, with monitoring the outcomes of the therapy and willingness to move on if the therapy is not working. And I think that this is even more apparent in the post hoc analysis, where it seems like, at least for EEN and CDED, these are therapies that work quite quickly in the vast majority of individuals. And definitely further studies on dietary therapy are needed, particularly those that address mechanism. So I'm going to stop sharing.
All right, thanks, Lindsey. Dr. Lewis has joined you back on camera now, and there have been a few questions coming into the chat box that he's been addressing. So I just want to give you a few minutes, Dr. Lewis, to answer them verbally and add more comments. The first one came in that said, any comments on your go-to maintenance therapies after using EEN? I find this to be the most challenging part. And we did post your response in the chat box, but I just want to give you a moment to expand on that.
Yeah, so I think that my experience is probably different than most of you in the world of pediatrics, because I almost never see newly diagnosed patients. So most of the people who I'm seeing are, referrals for secondary or tertiary care with established disease. So my predominant use of exclusive endonutrition as a bridge between two therapies. For somebody who, there's a reason we don't want to put them back on steroids, they're willing to try this as opposed to going back on steroids. They, for example, have lost response to an anti-TNF and are going to move on to a different biologic. There's going to take 3 weeks or longer to get through the process of insurance approval and getting their first dose lined up and all that. So this is a completely reasonable approach to avoid steroids in them. And I like sort of Lindsey's point about you have to just explain to them, like, this, you have to adhere to this like you're adhering to your drug, but it's only going to be for 3 to 6 weeks until your next drug kicks in. This is not a forever thing. Harder to do, obviously, depending on, if you're coming up on Thanksgiving, that's a hard time to do this. But for the right patient, I think it's a good option. So in my case, I always know where I'm going as we're starting, because it's a bridge. I think if Lindsey would be better qualified to answer what her approach is when they're newly diagnosed and this is their primary therapy.
Yeah, I think, we definitely use dietary therapy in that way as a bridge, but we also have used EEN as a transition to PEN for maintenance therapy. And this was really out of necessity and interest. We started using EEN in our patients for induction of remission years ago, and patients were feeling well. They were growing, they were not having side effects. Everyone was sort of happy with the therapy. And so we had to come up with ways to maybe expand the diet a little and modify this so that it could be used as a maintenance strategy. And so what we will frequently do is slowly decrease the percentage of calories from formula and increase the percentage of calories from solid food until we reach a point that typically ends up being, somewhere between 50 and 70% of calories from formula, where patients are still in remission based on symptoms and objective outcomes. And they're also happy with the amount of flexibility in the diet that they have. And I think we've also shifted our strategy where we are no longer saying, just eat whatever you want for your for like the solid food portion of the calories. We're trying to follow a pediatric anti-inflammatory diet pyramid that we developed. So I think we do this both ways. So we will sometimes use this as a bridge. We'll sometimes transition to PEN for maintenance. We will sometimes transition to a whole food based diet for maintenance, like SCD or CDED.
I would add, I think that is a good strategy, because whatever whole food diet you pick, there is a training just like there's 3 weeks to get somebody ready to in essence, get onto a next biologic. Like there's a training that goes into going on one of these diets, and the family's got to get ready. And so using EEN for a couple of weeks just while they're morphing their way into this is probably not unreasonable either.
Okay, great. So we have a few other comments in here about, again, with this being focused a lot on the induction data, there's questions around if G-tubes are worthwhile, and kind of understanding about how that impacts the outcome and things like that. And so there were a few kind of comments going back and forth with, curious to what is the difference in the centers that are participating in the CDED and PEN trials to have such good compliance. And then also, really just kind of exploring if we should consider G-tubes in patients, considering the high efficacy of EEN and the lack of side effects, but main barrier being difficulty to maintain monotony, palatability. And then there was also a question around, how do we factor in equity around that, knowing that some of these are more expensive therapies? So a lot to unpack there.
Yeah. So I guess I can start. In terms of the centers that are participating in the CDED trials, I think a few things. I think that these tend to be really motivated patients and families who believe in this approach and believe that diet is really critical and would like to try to avoid immunosuppression if possible. I think that there has a nice community has been built where people who have been following the CDED diet have organized recipes and strategies and tips and forums to communicate within. And so I think that that has also been helpful. There is, as many of you are aware, the Modulife program, which is an app, which I think is really nice for patients to track what they're eating and make sure that they are following the diet appropriately, with also some great instructions and recipes and things like that. And then a lot of the sites have a dietitian on the study team which has been, I think, really helpful for us as like a person who is almost always available for patients to call for feedback. I don't know if, Jim, you have anything else to add to that in your experience with dietary studies.
I think it's all about picking the right therapy for the right patient. You have to have somebody who's committed and wants to do this, and then it just becomes part of their life. I was going to just comment on the G-tube question. I don't endorse that at all. I personally, I think the mental health part of thinking about being on exclusive enteral nutrition for a very, very long time, I think that's probably not treating the patient as a whole. You're treating the inflammation, you're treating their malnutrition, but I think there's a mental health part of socializing and eating, and our goals should be to get to ways that people can eat some regular food, using continued use of partial enteral nutrition as to augment that response, I think is fine, but that you shouldn't necessarily need a G-tube. You should be able to use palatable formulas to get around that.
Yeah, it's very rare that we recommend G-tubes, very isolated situations, and only after we have confirmed that this is a patient that's a responder to dietary therapy. So like, it definitely would not be anything we would even consider in the induction of remission phase. We would want to make sure that that patient responded, and only if this is going to be a long-term therapy, like I discussed with the transition to PEN, but it's extremely, extremely rare, and really only, I think, in my experience, in situations where there is like an allergy or something that prevents consumption of a palatable formula. And then the question about equity, I think, is an incredibly important one and a tough one. These formulas are often not covered by insurance, even though we, argue and talk to medical directors and beg and ask for, a dietary therapy, which is cheaper than a biologic. And there's been a lot of advocacy work around this, and I do think it's getting somewhat better, but it's a huge problem that I don't have a fix for, that I think we need to continue to address. I mean, I think it definitely is a barrier. We try to get by with, with samples and patient assistance programs, but if the formula is not covered by insurance, it's a huge barrier, and we definitely need more advocacy surrounding this.
I guess I'd like to expand on that I think the equity issue goes even, I agree with everything Lindsey said, but I think it goes even beyond there. I think the equity issue starts at the level of having access to see a clinician who has expertise in the management of pediatric Crohn's disease or adult Crohn's disease and has some experience in this. I think the equity issue extends not just to the clinician, but most of the times dietitian is not covered by insurance. So this is out of pocket yet again. And, getting efficacy and sustained adherence to these diets almost certainly is going to be better with the help of a trained dietitian. And thirdly, even if you're thinking about these therapeutic diets, invariably the commonality across all of these therapeutic diets is that you are buying fresh food, fresh ingredients, and preparing them yourself. And not only is this likely more expensive, but it also means that you have the time to do this. There are so many. It's interesting because we usually think about equity around like access to super expensive biologics and things. Here's something that is necessary to sustain everybody, meaning food, and yet there are massive equity issues around this, starting, as I said, from access to the right providers to actually being able to afford the food, even if you're not using a formula.
Yeah, that's fantastic. Again, there's a lot of comments in the chat box about how it is way beyond the formula and the provider. It's lack of access to foods, it's money, education, families, situations, things like that as well. So we have about 3 minutes left. And I just wanted to mention, in the interest of time, those of you that have submitted questions that do not get answered, we will absolutely follow up with Jim and Lindsey and make sure that we get the answers and post them back here for everyone. I do want to mention or just kind of ask one final question before we hand it back over to Shahzad to wrap us up. What are your thoughts on involving a multidisciplinary approach, for example, with mental health professional as a more successful method when initiating a new diet therapy?
I think I'm always a huge proponent of a multidisciplinary approach when it's available. I think definitely including a mental health professional to address like the psychosocial aspects of the disease in general, but being on a dietary therapy. And I think we also, that could be really helpful in identifying appropriate patients for this therapy, especially from a pediatric perspective. Dietitians are critical, but I think that there are also in maybe places where there are not as many resources, there are certainly ways that I think we can think about, coming together and sharing resources. But yeah, I think a multidisciplinary approach is certainly the way to go, but not always available. And maybe there are other things that we can do to support people who don't have as many resources.
I have nothing to add because it was beautifully stated.
All right, well, thank you both. I will turn it over to Shahzad.
Thank you, Julie. Thank you, Jim and Lindsey. As you can guess, the cadence of questions, comments that are coming up indicates that this is a topic that is near and dear to many attendees and generating a lot of interest, resonating with the audience. I want to thank you and to thank Nestle Health Sciences for allowing us to share some of the expertise with our audience. So thank you so much. As a reminder for rest of the folks, we will be starting the regular session of the community conference at 11 a.m. Eastern and 8 a.m. Pacific, which is in about 30 minutes time. So please do join us, and hope to see most of you there. Jim, you're welcome to join us as well. You're one of us.
It was so nice to be invited to join the pediatricians world. You guys are awesome.
Thank you, guys. Take care. See you soon.
All right, thank you. We're gonna wait a few minutes as everybody exits out of here.